Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Diane Shannon. She's an internal medicine physician and a physician coach. Today's KevinMD article is titled, Physicians Have No Autonomy. Here's how to change that. Diane, welcome back to the show.
Thank you so much, Kevin. It's great to be here today.
So Diane's been on multiple times. Go to kevinmd.com/podcast. There's a little search icon in the upper right-hand corner. You can search for Diane's name in prior episodes to hear her story. Today, I want to talk about physician autonomy because I do think that it is a critical issue facing all clinicians today. The article is titled, Physicians Have No Autonomy. Here's how to change that. Diane, tell us how this article came together.
Well, mostly it's from my experience coaching over the past 5 years. And I coach frontline physicians. And I can tell you that the situation is pretty dire, what I'm hearing. And in terms of autonomy, it's a huge pressure. We know from the research that one of the key drivers of professional burnout is loss of control, right? And we have seen that over decades, but it's accelerated in recent times. And I'm just hearing over and over again about the places where physicians want to treat patients in a high quality, safe, compassionate way, and they feel like they're just being tied and can't do the things they know are right, which we know leads to moral distress and moral injury. So there's all kinds of connections and reasons why we really need to look at autonomy.
So give us some specific examples that really illustrate that loss of autonomy, because whenever we talk about moral distress, moral injury, burnout to the non-clinician population, sometimes there's a lack of empathy there because they don't quite know how that loss of autonomy can impact patients. So from your coaching other clinicians, what are some specific examples where that loss of autonomy can lead to detrimental patient care?
Right. So I think one example is there's a medication that is the number one thing that you should be providing to this patient, and you can't do it, right? Either it's a prior authorization issue, or it's just not on the formulary, or the cost to the patient would be so high, like they'd be choosing between eating and taking the medication, right? So what's best, and you can't do it. And the other big place I see it is time,
Mm.
right? Especially for primary care physicians who have that ongoing relationship with patients. And they are in this position where right now with a workforce shortage, both in support staff and in clinicians, if you say, well, okay, we have to deal with these two things today, we can't deal with the other seven,
Yeah.
you need to come back, and there's no slot for them to fit into, right? So you are feeling like either you have to do all of this and that then extend into after hours, right? Do all your notes after hours in order to do what's best for that person right in front of you. And we know that the more that you are working on the EHR at home, the higher your risk of burnout. And so that then leads to more access problems. So I think there's a direct connection between the physician being able to be there in the moment and do their best and their autonomy, their ability to provide the time and the medications and the clinical decision making that's really needed for best patient care.
So those two scenarios that you mentioned, not being able to prescribe a specific medication for a patient because of prior authorization, or not being able to address all the patient's issues in a single visit. How do those two scenarios impact physicians emotionally?
Oh my gosh. I, you know, I I think it just over and over again, when you think about why we came into medicine, right? All of us want to alleviate suffering. That's why we're here. If we weren't, we would go into something else. And here we are with a person in front of us, and we can't do that. And talk about stress level, and also just that wearing away of the meaning of why we do what we do. So a lot of the physicians that I coach will say, well, I can put up with this. Maybe it's a little bit of extra drudgery, the scut work, but if I don't see the difference I'm making, if I can't make a difference, if I can't do what I'm here to do, Why am I here? And it just really wears away at the energy and the bandwidth you have to show up every day. And I have learned that one of the key quotes, or that's like a red signal for burnout, is I dread going to work,
Mm.
right? Dread. And how long can you make yourself do something when you're dreading it? And how can you do it at your best, right? You can't.
Now, you've been coaching physicians for a while now. Now, these stories that you mention, these physicians losing autonomy, is it more frequent now than it had been in the past?
Absolutely. Yep.
A- And the theme that you mentioned in terms of whether it's prioritization, not enough time, the EHR, would they be universal across outpatient and inpatient physicians, primary care physicians, and specialists? Is it cutting across all specialties?
I think it is, but it may show up a little differently. So primary care, it's often about the time to develop those relationships, to have the access that those repeated visits need. In the ED, it may be there's such a backlog in terms of admissions that we are having to hold patients and we can't do the work we need to do, right? And also just in a way, the lack of relationships, or the degrading of the relationships between maybe the ED docs and some of the specialists, just because everyone is so busy, makes it that much harder to get those consults and have them happen quickly. Everybody is pulled just so thin right now.
So let's say a physician comes to you with that exact scenario, encountering moral distress or burnout because of the inability to provide optimal patient care. Take us into one of your coaching sessions. What kind of direction or advice or guidance would you give that particular physician?
Right. Well, I start off with the sense that really I divide training separate from coaching. And in my focus on coaching, I would talk about what matters to you, and then also going through their day and
Mm,
looking at literally what does their day look like, and where are the places where they have some control, where could they make a different choice. And I found, like, when you think about what the commonalities we have, those of us who end up in medicine, right? We do have some traits that are the same. And for example, perfectionism, people pleasing, or lack of confidence, those tend to come up and they can get in your way.
mm.
So being aware of where is it where my perfectionism is leading me down a rabbit hole, right? And I'm wasting energy. And where is it actually clinically necessary that this is perfect? So that's an example of, like, by raising awareness about that and helping the person to plan a little experiment, just slightly outside their comfort zone, to try something different and see what happens. And one of the biggest places I've seen this impact is with EHR and
Mm.
work outside of work. And so two things I would share is looking at pre-charting, and this is especially for folks who have ongoing relationships in primary care and other specialties. So looking at pre-charting, how are you doing it, when, having focused time to do that, and then trying to finish the note before the next patient. And even if it's not 100% done before the next patient, even if you're getting from 0% to 25%, it's that much less you have to do at the end of the day. And then we talk through what might you do to make that happen, to be able to finish the note in between.
For those physicians who say are unable to do that intrinsically, what are the typical barriers that you see that prevents them from doing that?
Right. I think one of them is interruptions,
Hmm.
right? So there you are trying to get your note done and you are interrupted every 30 seconds. So one piece that can help is to try to think upstream. Is there a way of batching those interruptions? So speaking with your MA or your nurse and saying, I'm going to check in with you halfway through the morning. If you could batch any non-urgent messages for me, then we can talk at that point. Then you'll have fewer interruptions when you're sitting down trying to get that done. And I think the other part is really looking at the guilt feelings that come up when you imagine that next patient is waiting for you. And there's this trade-off, right? You don't want them waiting extra too long, but on some level, are you going to kind of accommodate to the extent that at the end of the day, you have no charts done and it's all on your own time? So where is that balance?
So it sounds like these are all examples where physicians have to take that proactive approach, that prerogative to reclaim some of that autonomy that's taken away from them. Because if they don't do any of the things that you say, more and more autonomy would be taken away from them, and they may further spiral into burnout. So it's really up to the clinician to speak up, and whether it's batching interruptions and pre-charting, they have to take that proactive approach in order to protect themselves against burnout. Is that reading it correctly?
Absolutely. And I think one of the tricky places is when this starts to happen, you feel more and more like you have no choices, right? And it's turning that around to say, wait a second, where in my environment do I have a choice? And just trying one small change. And that small change can then help to get the energy to do more. And the way I think about it with one-on-one coaching is by my helping a single clinician have the bandwidth to begin looking at what are the practice inefficiencies or the organizational inefficiencies, that has this spillover effect that can improve it for everyone and make everyone's experience better. But if all clinicians are just trying to get through the day and don't have the bandwidth to put up their head and look at anything or take prerogative, then it is going to continue to get worse.
Now, give us an example or a success story of a physician who came to you with this exact scenario, and you coach them by reclaiming small moments of autonomy. Can you share a success story?
Sure. Well, I'll stick with the EHR example. So a physician who came to me, she was in primary care internist, working zero point 0.6 FTE, so 3 days in the clinic, and yet she was working every single day. And she came and she said, I just want one day off. I just want one day away from the monotony of doing notes every
Mm.
day, and has 3 small children and a spouse. And yet her weekends were taken up with this and her evenings, right? And so she did some of these specific small tasks. And the changes she started with were the pre-charting and the trying to finish before the next patient. And she came back 2 weeks later and said, I had a Saturday off. And then she kept at it and kept adding little tweaks to how she was working and the flow of patients through, and when she would have time to do the charting and the phone calls and the all the tasks that go along with that. And she got up to the point where she had 80% of her charts done by the end of the day. So there wasn't that much to do before she left. And she was then had the whole weekend off. Now for her, that she said, this has been 14 years. Why didn't I try this sooner? Right? So it made a huge difference in her experience at work and also at home. And she said, I realize now I was getting kind of bored because I was doing charting every day. And now I can put my focus back on the clinical work, which I really love.
Now, how difficult, from your experience, is it for physicians to change their mindset into that success story?
Gosh, well, let me put it this way. A lot of times physicians come to me when they're really at the breaking point and they're like, I cannot do this anymore.
Mm.
Something has to change. And for many of them, we're able to tweak where they are, the decisions they're making, where they set boundaries, and they can stay where they are and they find a way to make that work and have a sustainable, satisfying career. Some choose to leave that organization, and some, I would say this is rare, choose to leave medicine entirely or leave clinical practice entirely. My wish is that more physicians would seek help earlier,
Mm.
because that's the point where you could go from good to great instead of I am falling apart, my life isn't working, I can't do this, and now I'm desperate. And I can help you at that point, but it would be a lot more fun, easier, more productive to start earlier.
Now, these are great examples of fixing things on an individual level, but that doesn't take away from the fact that on a more macro level, more and more autonomy is being taken away from physicians. So, is there anything physicians can do on a more global macro level to reclaim some of that autonomy for the profession itself?
I think that comes from joining together, right? There's no one person can change, make those systemic changes. But together, when people have the bandwidth and they are being proactive to look at where do we need to make changes. One example that I would bring up is a non-disclosure agreement, right? So many of the physicians I work with, if they even think of moving to a different organization, they find they've got a year-long non-disclosure. And if they're in an urban area, that may cover every other place they would work without moving, right? So one individual is probably not going to be able to negotiate to get that out of a contract with a large health system. But if a number of physicians, a group banded together, or there was a professional organization working on this, that could be changed. So that's another example of where physicians' autonomy has been constricted. Your autonomy to
Mhm.
choose to leave where you are and go to work somewhere else that maybe has a better culture or better benefits or just a better work life. And so that's an example of where by banding together, maybe we could get that changed.
We're talking to Diane Shannon. She's an internal medicine physician and physician coach. Today's KevinMD article is titled Physicians Have No Autonomy. Here's How to Change That. Diane, one of the things you said earlier is that you want physicians to seek help on an earlier stage rather than letting things get so dire that they're thinking of leaving their jobs or leaving medicine completely before seeking help. So, what do you mean by that? Do you mean coaching? What other resources can physicians turn to when you tell them to get help earlier?
Right. Well, I think there's always, mental health professionals, right? That is a place to stay and to try. And that works very well in parallel with coaching. Not everyone needs that, but that's definitely something I want to mention, and especially for physicians who are at risk, right? To take a step to get help early. Coaching is another example, either individual or group. And I think also reaching out to peers and mentors, just to let people know you're struggling. And that can be a very hard thing to do, but even to start those conversations, to begin to rebuild the camaraderie that we also have lost over the past years, right? As we've become more busy, as there are fewer opportunities to meet in person. So I think that's a really important piece, is looking for where can I find that connection, benefit both in person and also online.
And my final question, Diane, tell us some of your take home messages that you want to leave with the Kevin MD audience.
Right. I think, one that I've said before is we're human, right? And I think as physicians, somehow that we get this message that we're not human and that we can withstand anything and keep going. And I myself have found that this is not true, and it's not true for any of us. And we deserve to have lives that work.
Diane, thank you again for coming on the show and sharing your perspective and insight.
Great. Thank you so much, Kevin.